Hello, good evening, and welcome everybody to this evening's Facebook Live. I'm sure most of you know who I am by now. My name is Alec. I'm the MD of Wound Care People. This evening's session, brought to you in partnership with Essity, is Antimicrobial Stewardship in Wound Care, sharing best practice. I'm very pleased to announce, in fact, I'm so pleased that I've worn a tie this evening for the first time, to introduce two absolutely fantastic ladies and two fantastic speakers. So firstly, we have Professor Val Edwards-Jones from Manchester Metropolitan University. She's a visiting professor of Skin Integrity and Infection Prevention Research Institute at the University of Huddersfield. And we have the glorious Jenni MacDonald, who's the lead nurse for tissue viability from NHS Lothian in Edinburgh. Ladies, are you there? Can we just check? Are you with me?
Hiya.
Yeah. Jenni, how are you?
Good, thanks. Good.
Excellent. I know you're really looking forward to this evening, so that's great. And Val, where are you?
Yeah,
how are you?
I'm good.
Excellent.
I'm good, ready.
Fantastic. So, like I said, this tonight's session is brought to you in partnership with Essity. So I'd like to thank those for their support for the event. Certificates, as always, will be available via links at the end of the broadcast. Bear with us if we have any technical issues. I know we say this all the time, but you can see that we're obviously broadcasting this from our own homes. So do bear with us. Please make sure you ask as many questions as you possibly can over in the right-hand side of your screens. We'll come back for a live Q&A after the presentation from Val and Jenni. So without further ado, I'm going to hand over to these two wonderful women, and I will see you back here very shortly. Thank you.
Okay, thank you, Alec. And thank you, ST and JCN, for inviting me to speak. It's a very pertinent topic, especially when you hear some of the information I have to give you. But one of the main things I want you to learn about tonight is the importance of antimicrobial stewardship in wound management, and perhaps explore how we can implement best practice going forward. Antimicrobial resistance, some of the current status, it's increasing. It's increased dramatically since 1990. And most worrying, what we're seeing is resistance of first-line antibiotics to common infections. So what I mean by that, so if in the past, if we had gonorrhea, we would have been treated with penicillin. Now that's no longer of any use, and we're using 2 antibiotics, and we're seeing resistance develop in those. Treatment for tuberculosis used to be 3 months. It's now 2 years for the multi-drug resistant strains, if we can eradicate them. The big worry is we're seeing antimicrobial resistance in common wound pathogens as well, such as methicillin-resistant Staph aureus. We're also seeing them in E. coli and other Enterobacteriaceae. We are being left without any antibiotics to treat common infections. And it is predicted by 2050 that antimicrobial resistant infections will outpace cancer as cause of death. So it's extremely worrying. We've got a 30-year window. So we've had 30 years of it developing, and we've got 30 years to stop it happening any further, but we need to stop it now. The World Health Organization has listed antimicrobial resistance as one of the 10 greatest global threats. And if you actually look at that, there's another 4 or 5 associated with antimicrobial resistance and infection, and the other 5 are things like environmental issues. So we really have to concentrate on antimicrobial stewardship, and I think for a lot of people, you need to know what it is. It is a solution for reducing and preventing further antimicrobial resistance from developing, and it's got to be a multimodal approach. It has to be a teamed approach, and we've got to promote good use of antimicrobials to preserve their effectiveness. And we need a systemic change, and we need to increase awareness in the public so that they have to stop going to GPs and demanding antibiotics for sore throats, etc. In wound care, some of the things that we need to try and really focus on going forward is early identification of infection and preventing infection in wounds, and obviously the appropriate use of antimicrobials, both systemic so antibiotics, and topical antimicrobials, antiseptics. Just very briefly, antimicrobials is a generic term we use for anything that will inhibit or kill microorganisms. Antibiotics, you use them. So everything that we know about antimicrobial stewardship is underpinned by education. So we need to look at effective infection control methods, and we need to know when to use antimicrobials, whatever they are, effectively. So we need to know what to use, when to use it, where to use it, how to use it, and for how long to use it. So some very important key questions. So governing antimicrobial stewardship, Centre of Disease Control and Prevention have promoted 7 elements which are necessary. That is leadership. So we need someone to govern and look after the whole gambit across the world and across the country. People have to be accountable now for antibiotics that are being used. We need drug expertise amongst pharmacists, so it's really important that pharmacists get on board with this. But what you will find is in a team of people who actually oversee antimicrobial stewardship for the trust and the community, there's nearly always pharmacists involved. There has to be appropriate action taken, but we need to be able to track the importance of what happens. We also need to give out appropriate reports frequently, and we need to educate users. So whose responsibility is it for antimicrobial stewardship in wound care? Well, I can tell you it's everybody's. Everyone that looks at a wound, you should be thinking, is it possible I'm going to be, I'm overprescribing here? So from a national and an international level, I've already spoke about World Health Organization, but obviously in the UK, we look at the National Institute for Health and Care Excellence, NICE, and they gave us plenty of guidelines. But it's also the public responsibility to stop using antibiotics inappropriately. You know, let's not buy them off the internet, which sometimes people do. And that's under the governance of the Public Health Board. Clinicians, we have relevant clinicians, nurses, podiatrists, support staff, paramedics, etc., who all need training and educating appropriately. The patient and the patient's carer needs to understand how important antimicrobial use is, when to use it, how to use it. And obviously these all transcribe into local and national policies. We need a multimodal approach, and what do I mean by that? Well, it's increased public awareness, and it involves local, national and international organisations. We must change practice. We cannot continue using antimicrobial agents as we are, because it does mean by 2050, a simple operation that you might go in for, if you contract a multi-drug resistant infection, there will be nothing to treat you with. So it is that serious. We need education, good education, and someone has to take responsibility for this change. The multimodal approach in wound care requires an accurate assessment of the wound. So we need a tool to help consistent diagnosis of local infected wounds across all care pathways. We need to reduce antibiotic and antiseptic use to only when we actually need to use it. So instead of saying, oh, well, I'll just shove a silver dressing on here, or I'll use a bit of iodine here, you need to be thinking about what you're doing with antiseptic dressings. And for whatever you do, you must stop prescribing antibiotics where they're going to be of no use. There's an interesting paper out about 3 years ago which demonstrated that almost 70% of all antibiotics prescribed by GPs were unnecessary. So it's something to think about. And we need to use dressings with perhaps a physical mode of action. I am going to talk about that a bit later on. So dressings that perhaps can aid with debriding and cleaning without the use of antibiotics. This is a diagram to show what a multimodal approach is, certainly with antimicrobial stewardship in wound care, and you can see education is key. But it's all about the role of national, international organisations, traditional processes, knowledge of a multidisciplinary team. We know that we don't stand alone. We need to include the family and carers. And we need to have accurate assessment and understand clinical signs of early infection so that we don't have to use antibiotics unnecessary. We need to minimise the use of broad spectrum antibiotics and go for targeted treatment. So that means we actually really need, when there is a genuine wound infection, we need to know what the causative organism is. We need to use dressings that has a physical mode of action instead of always antimicrobial dressings. And we're going to talk about that. Responsibilities and expectation of the patient. They need to understand why perhaps they're not having antimicrobials prescribed for them. And we need increased public awareness. So we need to know that education is key, and it's the responsibility of the whole of our wound care group to educate patients, families, carers, and perhaps other healthcare professionals. There's also a need to to explain what antimicrobial resistance is. Not everybody understands it, but if you have a nice easy antibiotic, like you can use erythromycin for a respiratory infection, so a patient can get antibiotics in tablets. But if you get a multi-drug resistant infection, and certainly it's interesting in the current COVID crisis, you no longer can treat with a nice little pill. You've got to take them into hospital and give them intravenous antibiotics, which may or may not work for pneumonias. And it's very, very sad that we have lost the ability to treat with first-line antibiotics. We need to say why it's a concern for the whole world, not just for them. And we need to discuss strategies that will reduce the risk of wound infection, and things like hand hygiene and surface cleaning to maintain a clean environment is important. We need to provide advice on signs and symptoms of wound infection, and we need to explain when to seek urgent clinical attention and highlight the need to follow treatment plans and to follow them correctly, not deviate. So education underpins everything, and we know that's very true in your nursing council with your continual professional development. But certainly on antimicrobial stewardship, it needs to be a vital component. We need to understand infection prevention and go back to the basics. And COVID's an excellent indication of this, because washing your hands, keeping your distance, and cleaning your surfaces, etc., is all shown to be extremely good at preventing a lot of infections. You need to understand what the infection continuum is. It isn't just, oh, there's a bug goes in the wound, or you'll get an infection. It's far more complicated than that. And it's important you know when it's actually an infection rather than an organism colonizing. And understanding what antimicrobial treatment is available is also key. So if we can prevent infection in the first place, it's one of the best ways to reduce the need to prescribe antibiotics. And every infection that is prevented will reduce the need for the use of antimicrobials. That's cost saving, and it also lessens the development of resistance. So this is a diagram of the wound infection continuum put together by the International Wound Infection Institute. And what you can see here at the bottom is contamination. So when an organism enters a wound, it then has to colonize the wound. So it has to make that wound home, if you like. And it's a fine balance of when an organism is just happy living in a wound, to then it tips over to a local infection. You need to understand what signs and symptoms of a local infection are in an acute wound, which is often easy to recognize compared to a chronic wound. If the wound becomes a spreading infection, you really have to think about intervention. And if it's a systemic infection, if the organisms enter the bloodstream and we're going into sepsis, again, that's vital. This is all to do with increasing microbial virulence and numbers. And certainly in chronic wounds, we know that 80% of all chronic wounds have a biofilm. And I'm going to explain that in a moment. But just to reiterate this, with contamination and colonization, we need vigilance, local infection, etc. You need to think about intervention. So, definition of a biofilm. These are surface attached communities of microorganisms that become encased in a matrix of carbohydrates and protein and DNA, and they assume a phenotype totally distinct from planktonic free floating cells. And in the laboratories, it's planktonic cells we deal with. So the ones attached are called sessile cells, and the free floating cells are called planktonic. So as you can see with the diagram on the bottom left, we've got organisms that will attach to a surface, and the minute they're attached to a surface, the surface changes. So other microorganisms can attach. They then start to secrete an extracellular substance that's like glue, and it's very difficult to remove, and that encases them, and it protects them from the external environment. And one thing we do know is if you're putting topical antimicrobial agents on a biofilm, if it doesn't disrupt the biofilm, you need 1,000 times more antimicrobial agent than you would in a clean wound without a biofilm to actually kill the bugs. You have a very distinct window where you can actually treat topically, and Jenny's going to talk about that. And if you look on the right here, this is to demonstrate a biofilm. This is a times 700 magnification using an electron microscope. In fact, it's a times 5,000, sorry. Got me notes wrong. But you can see the bacteria in the middle and all the extracellular matrix that's encasing it and protecting it. So I just want to hand over to Jenny now, who's going to talk about clinical practice.
Thanks very much, Val. So hopefully I can bring some clinical perspective on what Val's just told us. So I'll kick off with antimicrobial treatment selection. Now, we have to take into consideration your local policies. And the reason we say that is actually antibiotic sensitivity it varies depending on your geography and where you live. So that's why we always say to refer to your local policies. We have to, in terms of our caseload, but also our organisation, regularly review antibiotics, whether that's systemic antibiotics or the topical antimicrobials that I'll be talking a bit more about. And that includes frequent holistic reassessment of the wound. But if you think back, certainly I'm a nurse, and in nursing school, we're taught the 5 rights of drug administration. Now, those 5 principles apply to topical medicines as well. So we always have to remind ourselves when we're assessing a patient that we have to ask ourselves, is this the right patient? Is this the right drug? Is the right time, the right dose, and the right route? So not to labour too much on the point around the wound infection continuum, I know Val's already touched on that, but this is such a handy tool to have out in practice. I know a lot of district nurses that have got it printed out A5 and are stuck in the back of their diaries, and it's a really helpful tool when you're assessing or trying to diagnose whereabout on the wound infection continuum your patient's wound is. And depending on that diagnosis and where your patient is in the wound infection continuum will tell you what you need to do in terms of treatment planning. So as Val said, all wounds are contaminated, and actually the wound infection continuum is a bit of a slippery slope. And it's up to us clinicians to prevent our patients going into spreading infection, tipping into systemic infection, and then obviously we're considering and worrying about potential sepsis. One top tip that I could give you in clinical practice, it is very difficult to tell the difference between local infection and spreading infection. So what I always have in my tool bag is a skin marker pen. So when a wound is infected, we all know the clinical signs of infection, and one of those is spreading erythema, so redness around the wound, so the peri-wound area. What I find really helpful is to use the marker pen to mark around the erythema. The next time you see the patient, and certainly if you're concerned, you should be seeing them sooner rather than later, the marker pen on the patient's skin will give you a guide to whether that patient's infection is relatively stable in the local category, or has it surpassed your marker pen, which means that the patient is in the spreading infection, potentially going towards systemic infection. Patient history is so important here when you're trying to do this diagnosis. You want to listen to the patient's signs and symptoms of infection. And what you want to try and gauge there is how quickly this infection is spreading. Is the signs and symptoms of pain, exudate, increased redness, have they started to increase over the last 1 or 2 days, or is that the last 1 or 2 weeks? Now that will give you an indication to where the patient is on the infection continuum. Now don't forget, if you are suspecting spreading infection, or hopefully not, but systemic infection, then we have to do our observations using the news chart, and that is obviously our screening tool for sepsis. More locally, in NHS Lothian, certainly in NHS Scotland, we use the Scottish Ropper ladder, and it's very similar to the wound infection continuum. The Ropper ladder was actually developed by our good colleague Ruth Ropper in NHS Lothian, and is used right across Scotland. And the good thing about this tool is it actually gives you guidance on when to swab and when to start topical antimicrobials. So again, another key document for the back of the diary. So to go on about swabbing, this is always a contentious topic, and I think we over swab, and I think everyone watching tonight will agree with me, but we really shouldn't do it routinely, certainly not without any rationale. You have to ask yourself, if I'm going to swab this wound, what do I hope to achieve from the result? So we swab a wound to isolate and identify any microorganisms in the wound, and we use that result to allow us to make decisions around antibiotics. But actually, if you're not going to change your treatment plan based on the wound swab results, then you have to ask, do I really need to do this? Consider the cost and implications. In my organisation in Edinburgh, a wound swab costs us £13. And if you're not going to change your treatment plan, or your patient's antimicrobial treatment plan won't change, then do we really need to swab? We swab after cleaning, and there's different techniques to swab as well. We know more recently that the Levine technique of obtaining a wound swab is the most accurate. And if you want a better description on why that is the case, then I would suggest reading chapter 18 in the Royal Marsden Clinical Nursing Procedures book. That will go into the different techniques and tell you why we use the Levine technique more so in the last few years. Now, wound swabbing is helpful in acute wounds. However, it's not so helpful in chronic wounds, and I'll go on to explain that. So acute and chronic wound infection is very different. And essentially an acute wound, if it is infected, it's very, very easy to tell if a wound is infected in an acute wound. So the diagram you've got in front of you is a nicely sutured wound closed by primary intention. And if that wound, for example, was showing signs and symptoms of infection, it would be easily identified. Now, when a swab in an acute wound is helpful, is usually, majority of the time, when an acute wound is swabbed, the results will come back with a single organism. And that will allow us to prescribe antibiotics. So that is relatively straightforward. Where it gets a little bit more complex is in chronic wounds. And it's complex for a few reasons. As you know, wounds go through 4 stages of normal wound healing. And there isn't a definition of what's an acute wound and what's a chronic wound. We generally understand that chronic wounds don't follow the nice 4 phases of healing. They become stuck. And they become stuck in the second phase of healing, which is the inflammation phase, which is normal for wounds for a couple of days. However, chronic wounds get stuck and they look inflamed, they look red, they look hot all the time. And that's when it's really difficult to recognize, is this a chronic wound being a normal chronic wound, or is this now infected? And it's very, very difficult to tell the difference. Where swabbing in chronic wounds is not so helpful, and everyone who's swabbed a chronic wound and watching tonight will know that that wound swab is likely to come back mixed growth. And as a clinician, you're thinking, right, okay, mixed growth, what can I do with that? And there's not much we can do. Chronic wounds, about 80% of chronic wounds have biofilm, and I know Val's touched on biofilm. But when we're looking at antimicrobials, antimicrobials, biofilm is super important. We have to understand what that means. In terms of prescribing antibiotics in chronic wounds, there's no evidence if the wound is locally infected that will make a massive difference. The only time you would have antibiotics prescribed in chronic wounds is when the patient's tipped into the spreading or systemic infection stages on the wound infection continuum. To go back on to biofilms, like I said, it is super, super important, and the majority of wounds we look after now are chronic wounds. And if we think of all the wounds that we're looking after that are chronic, 80% of them have biofilms. Now, as clinicians, what we need to do is we need to reduce that biofilm, and we do that through debridement. We need to do debridement quickly, and we need to do it often. When we're assessing the wound, we can take for granted that 80% have biofilms, and we need to be not only debriding that biofilm, but we need to stop it forming. Biofilms reform between 24 and 48 hours. And we have to be looking at, obviously, we assess the wound, we debride the wound in terms of biofilm, we cleanse, and then we use our antimicrobial. A question as TBNs always get asked, how often should I be changing this wound dressing? And there is no fixed rule on how often you should change the dressing. Usually that would be based on holistic assessment and very much based on what the wound is telling you, and obviously the patient themselves. Obviously, if you're concerned about the patient's infection status, you would be reviewing them more frequently to try and prevent them going down that slippery slope to spreading infection. Obviously, if exudate volume we have to be thinking about as well. We will need to be changing that dressing more frequently if the volume of exudate's higher. Now, this is a stolen image from Palm Spruce, so thank you very much. It's one of Val's friends there. And this really, really is a great diagram to show what we need to do as clinicians to biofilm. So if you look at the very left-hand side, like Val said, the biofilm is a community of all these microbes living in a little igloo of a protein matrix. Now, when we apply our antimicrobial wound dressings, and we're talking, well, I'm certainly talking about antimicrobials that donate into the wound bed. So that could be your honey, that could be your silver, or your iodine-based products. If you've got a biofilm on the wound surface and you put your antimicrobial on the top, it can't penetrate into the wound bed. So that's why debriding that biofilm is so important. So we have to debride the biofilm. You'll see as we move from the left of the screen over to the right, we disrupt the biofilm, the protein matrix they're happily living in, and we actually start getting rid of those microorganisms. Then we cleanse, we get rid of some more, and then we dress. So the idea is not only to disrupt the biofilm, but to suppress it with your antimicrobials. If you don't address your biofilm, you have to ask yourself, what effect am I getting from these antimicrobial dressings? And actually, if we're not addressing the biofilm, is there any point in using them? So identifying when to use your topical antimicrobials. Like I said, it is difficult to tell where the patient and the wound is on the wound infection continuum. Sometimes you've got to listen to what your patients are telling you, but also what the wounds are telling you. These signs might be very, very subtle. So you're looking for things like increase in exudate, increase in pain, increase in redness, increase in temperature, odor as well, but also measurements. Now, I think that's something we're not great at in wound care. Measurements. So very, very simple, a paper ruler, we're measuring in centimeters. But just remember, if your wound is deteriorating, and certainly in terms of infection, it can be the centimeters that change before any other signs and symptoms. So please, please remember to measure your wounds. If your wounds, the signs and symptoms are changing, then this is when you need to be considering your topical antimicrobials. You need to diagnose where your patient is on the wound infection continuum. Is it local infection? Is it spreading infection? or is it systemic infection? Think about red flags. Is the patient at risk of sepsis here? And remember your observations. Obviously, the clinical picture is getting quite serious now when we're talking about spreading or systemic infection. So we'll be considering topical antimicrobials, but also your systemic antibiotics. So when spreading infection happens, that's when we need to be looking at systemic antibiotics as well. In terms of biofilm, we need to continuously think of biofilm and biofilm-based wound care. We need to have that at the forefront of our mind. The 2-week challenge. Now, a lot of us would have heard of the 2-week challenge. And that's certainly around using topical antimicrobials. Infected wounds should be assessed and reassessed frequently as required. And sometimes that might have to be daily initially. Some dressings can be in situ for up to 7 days. But obviously in terms of exudate and volume and monitoring that infection, you possibly wouldn't leave your patient for 7 days. So what you need to be thinking about is after 2 weeks of using an antimicrobial, whichever one that is, if the signs and symptoms have resolved, that's when you stop. That's when you stop the antimicrobial on your patient's wound. However, if after 2 weeks, there's still signs and symptoms of infection, feel free to continue. So you can continue the antimicrobial for another 2 weeks, but please document it that that patient is on their second phase of antimicrobials. The third thing you need to think is if there's no improvement in this patient's wound after 2 weeks of the same antimicrobial, you might consider changing antimicrobials. So if you were using silver, for example, you might change to honey or an iodine-based product. So after 2 weeks, think to yourself, do I need to stop this? Do I need to continue this? Or do I need to change this? In terms of evidence-based pathways in the fight against antimicrobial resistance, pathways are really, really helpful. And that's because we want to maintain continuity when we're looking after patients and their wounds. And often it's not the same nurse or maybe not the same podiatrist. So actually following a pathway and making sure we're all doing the same things and triggering wound swabs, we're triggering topical antimicrobials, and we're triggering systemic antimicrobials all at the same time gives us that assurance that the patients are receiving adequate and evidence-based care. We have to remember the five R's that I talked about in the beginning, and obviously using the best practice statement by Essity for antimicrobial resistance and wound care is they've got great pathways in their best practice statement, but please remember documentation is key, and so is photography. Photography in wound care is really helpful in terms of providing that continuity of care. And on the next slide, I have got one of the clinical pathways based that's in the best practice statement from Essity. Now, I've talked to you about topical antimicrobials and how they donate their silver or their honey or whichever one you're using. And essentially, the antimicrobial would kill the bacteria in the wounds. Now, I'm going to hand over to Val, who's going to give you a different perspective on antimicrobials. And actually, not all antimicrobials need to donate into a wound. Over to you, Val.
Thanks, Jenny. So on the next slide, I'm actually going to be talking about some quite new dressings. They've been out a few years, perhaps not used as often as they should be, but these are these are dressings that are made with a physical mode of action that allows the dressings to actually remove bioburden from the wound without the need of an antimicrobial agent. And this is due to, usually it's an interaction, a chemical interaction, and it will actually, when you remove the dressing, you remove most of the bioburden. And in the diagram on the left, you'll see that these the Cutimed Sorbac dressing actually claims to bind, pacify, and remove microorganisms. Now, I had a bit of a laugh when I saw the term pacify, because what it actually means is it stops growth of, it starts to inhibit growth. There's no known side effects to these dressings, and the microorganisms actually retain in the fibre of the dressing, and there's no resistance likely to develop because it's not an antimicrobial agent, so it isn't a chemical. So these have been featured in recent documentations which are available. So to give an example of Cutimed Sorbac, these are coated with diacyl carbamoyl chloride, or DAC, as you may know. And what it is, it's a type of lipid-based chemical that allows the microorganisms to actually firmly attach to it. It's very hydrophobic, so the microorganisms will, in a wound, if it's placed on a wound bed, it will swim to the organisms. If they move and that, they will move and be enclosed and encased in these fibres. So they are extremely exciting going forward without the need of any antibiotics or antimicrobial agents. There was a good review on Sorbac technology undertaken by Paul Chadwick and Karen Uzi in 2019, and I do believe you can ask for one of these references. And it actually, their major conclusion was that these dressings will provide an important contribution to you going forward, trying to monitor antimicrobial resistance. Because the one thing you think about, because of its chemical interaction, it's not about antimicrobial resistance. That is a physical thing. So the worry of antimicrobial resistance, an antimicrobial sensitive organism and a resistant organism has exactly the same chemistry. So there's very little evidence of it developing resistance. So what's the key points going forward? So we need a multidisciplinary team, education's vital. We need rapid intervention for a spreading infection or a systemic infection to try and reduce the need for long-term antibiotics. Topical antimicrobial treatment needs to be monitored and managed in exactly the same way as antibiotics are. You need to understand dressings and the dressing properties, and whether or not you really need an antiseptic, which is another term for antimicrobial, or whether you could just use a physical dressing. You need to know when and how to apply antimicrobial dressings correctly. And the clinical decision making, you must have at the back of your mind antimicrobial resistance and antimicrobial stewardship. And I will emphasize that change is very, very difficult for anyone. But in the current climate, it's absolutely essential that we do think and we adhere as much as possible to antimicrobial strategies. So Essity has produced some support and educational tools, including an academy for education, bite-sized learning, there's ambassador programs and support with the pathway developments that you require in your practice. There's a best practice statement just come out on antimicrobial stewardship for wound management, which is a really interesting read. I've given 2 or 3 pages of references which you can enjoy and look at in your own time. And what I'd like to do now is hand back to the chair, ready for the question and answer session.
Thank you very much, Val. Sorry, I muted. Thank you very much, Val. Thank you very much, Jenny. It was a really interesting conversation. It's a really interesting subject, actually. I always think about seeing a couple of years ago in a supermarket somewhere a toothbrush which had silver ions in it, and it said that basically, and it was talking about it being an antimicrobial type of toothbrush, and it got me thinking that that's you know, where we are right in this sort of this situation where we're overusing things as antimicrobials. So it's a really fascinating subject. We've had loads of questions both, so I'm going to get straight onto them. The first question is from actually I'm not sure who it's from, but it said should nurses educate patients on AMS? And this is for you, Val.
Yes, absolutely. There should be some tools available for nurses. It's the nurses who see the patients and the carers. And I'm not saying that they need to stand there with a lecture board, etc. But there should be some very brief conversations had about antimicrobial resistance and how you perhaps are going to manage the wound. You may think it looks infected, but we're going to try and manage the wound without the need of any antibiotics because of the problem with antimicrobial resistance. And it's about the nurses having enough knowledge to answer the questions correctly.
Yeah, excellent. Thank you. Question 2, this is for you, Jenny. When would you not debride?
And that's a great question. I like 90% of the time I debride because, like I said, 80% of our wounds have got biofilm, and we're not going to get the best out of our antimicrobials if we don't. There is a small percentage of the time that I wouldn't debride. One, if the patient wasn't able to give me consent for any reason, whether it was a mental health reason, whether it was something like dementia, for example. So consent is the first thing that I wouldn't necessarily debride. Other situations, so I would be more confident to debride whilst I was in a hospital, for example, because you have a team of people around you. If the patient was to have a bleed, for example, and you probably wouldn't take that risk all the time if you're in the patient's home, for example, because actually that's a higher risk situation. I also wouldn't debride if the patients were on anticoagulant medications. Again, there's a risk of bleeding there. And probably 2 wound types I wouldn't debride. Fungating tumours obviously are very friable and at risk of a catastrophic bleed, so you wouldn't debride those. And end of life as well, Alec. Your skin fails at end of life, as you know, and your treatment goals are very different. So actually, we want to debride to get rid of biofilm, we want to debride to get rid of devitalized tissue. But if the person is nearing the end of life, actually you're thinking about comfort and you're thinking about odor control. So I probably wouldn't debride at the end of life either.
Yeah, brilliant. And I guess there's also the sort of the confidence and the skill level, making sure that, if you're going to debride, because it's quite a, in particular, if you're looking at sort of necrotic wounds and things, making sure that you've got the right education, the right skill level to be able to do something like that.
Absolutely.
Okay, so number 3, this is from Alison. How do we educate GPs to differentiate between red leg syndrome and actual cellulitis and appropriate antibiotic use? And I'll pass that one to you, Val.
Well, it just comes out, it's all about education. I think one of the problems of many GPs is we know they're always extremely busy, and many GPs, certainly old school GPs, will be relying on knowledge they acquired many years ago, and things change very rapidly. The whole concept of biofilms was only came out in 2008, associated with wound care, although they'd been out associated with respiratory disease since about 78 and catheter infections. But unless GPs are being updated constantly and educated, they will still rely on what they were taught. And I think it's about trying to perhaps get into some of the Wednesday morning sessions that GPs have to update themselves in their practice. And it might have to be something as local as that to get them to change, or at big conferences, and guidelines can go out to them, certainly under the Antimicrobial Stewardship guys in the trust, because it goes out to community care and community practice, and that information should be disseminating down. There is an incentive for GPs to stop prescribing antibiotics. It's been one of them that was given out from the government. So they're trying to reduce antibiotic usage in their practice by at least 5% every year. And if they meet the targets, they will have an incentive for their practice. So we are trying to educate GPs, but that's one of the biggest problems.
Yeah. Jenni, yeah, I was just going to say, just before I come to you, Jenni, just to Val, you just mentioned about the, getting in front of GPs on their Wednesday morning meetings and things.
Yeah.
Who are you talking about specifically going to do that? Who do you think should do that? Are we talking about nurses doing it, industry doing it?
It could be both. It could be both. They do. I know sort of GP practices do invite industry in and nurses, and it may be that the nurses themselves who are working in the practice, who are specialising in wound care, they should be given tutorials. And sometimes it's very frightening for people to do that, even in a small group of 5 or 6 people. So it might be something wound care societies or industry might want to help support nurses in the practices delivering this information to their peers, really.
Yeah.
Because I think it can be a bit daunting.
Yeah, no, I agree. Jenni, sorry, I didn't mean to cut you off. You were going to jump in there with something yourself.
Yeah, I'm just we keep referring to the best practice statement from the Antimicrobial Stewardship that we're referencing today. Something like that is a great tool to help GPs. And again, going back to that pathways, Alec, the pathways are not just for nurses or podiatrists looking after wounds. They're great for a GP surgery wall as well, and can really help GPs make that clinical decision. Because like Val said, the evidence is changing all the time, and we're all trying to keep up, and that includes GPs.
Yeah, brilliant. So we've got loads more questions. Question number 4 is from Helen, and this is: if a patient is a high risk with slight redness of surrounding skin, would they need more aggressive treatment, such as antibiotics for local infections? I'll pass that to you, Jenni, to start, and then we'll see what Val thinks.
Yeah, so in terms of systemic antibiotics, so that's your oral antibiotics to begin with, we wouldn't be initiating them at the local infection. Again, print off the wound infection continuum. When the signs and symptoms start spreading, that's when we need to be looking at systemic antibiotics. Ideally, what we want to do when that patient is showing local signs of infection, we essentially want to nip that in the bud, if we can, with their topical antimicrobials. Now, patients will be at higher risk, your diabetics, for example, and patients that are immunocompromised, for example. And actually, if you look at your biofilm management, if you get your topical antimicrobial on, hopefully, the idea is we can prevent the patient slipping down to that spreading infection. Some patients are higher risk than others, and they might require more frequent wound assessments or visits, for example, to keep an eye on them.
Brilliant. Val, anything you want to add to that?
I would say certainly with, if you look at the guidelines for diabetic patients, they often refer to a wound that's they're really concerned about, where they think there may be a local infection, and they will do everything Jenni says, but also they will take a swab at that point. And if they're so concerned about that patient, they will take a swab, send it to the laboratory. They will start them on an empirical treatment, which is usually amoxicillin. It's usually a beta-lactam. And on receipt of the swab, it may well say, oh, we have a Staph aureus in here going to an osteomyelitis. So the treatment would be changed. So they would have flucloxacillin added, or if it was an MRSA, they'd have something like vancomycin added. So, but at that point, it's quite a pertinent question. It would be, that's when the laboratory would be useful to identify if there was a pathogen present there that could cause concern. And that's in a high risk patient with signs of local infection, potential spreading. But if they had no signs, I would not put them on prophylactic cover.
Okay.
With antibiotics.
No, 2 really good responses, actually. Question number 5, and for all of you people who are still with us, do keep your questions coming in. We're going to keep going until about 8:30, so we've still got a good 10 minutes to try and quiz Jenni and Val as much as we possibly can. Question number 5 is, and this is from Ali, and I think I probably know which Ali. Do you recommend mechanical debridement, such as a monofilament pad, to disrupt biofilm? And I'll put that to you, Jenni.
Absolutely. I was just talking about this today.
There, that'll do. Absolutely, that's fine.
Was that the answer to the question, or would you like me to describe it, Alec? Are you happy with a yes, no?
No, keep going. I was kidding.
So mechanical debridement, as we know, there's lots on the market at the moment. Essentially, it's either a pad or a cloth that essentially has got microfibers in it, and you can physically, mechanically debride that biofilm. Like I was saying earlier, we need to disrupt the home of the microorganisms so our antimicrobials can actually take effect. And if we don't, things like your gauze swabs are just not going to cut it. You do need a mechanical debridement. Ideally, sharp debridement would be the best, but you have to do your advanced courses for that. And anyone trained with your mechanical cloths or your sponges can mechanically debride. So absolutely, like I say, I debride 90% of the time.
Excellent. Val, do you want to add anything?
Yeah, I just want to add something of some of the new developments coming out and new dressings that will be on the market, because industry is very aware of the problem, certainly for community nurses, not so much TVNs and fully trained podiatrists, but to make dressings available that will debride and collect stuff from the surface of the wound simultaneously. So instead of having to physically do something, there are dressings that will be coming out that will have a surfactant in them, or the fibers will do it, and you'll be able to dress a wound, and that will keep cleaning it, as well as your gels and things. But there are some exciting developments coming out, but a lot of these do need to be proven rather than just accepted. So there's some interesting stuff coming about.
Yeah, and you mentioned earlier about the fact that biofilms really didn't become a well-known thing until about 2008, and for industry to be able to sort of to be able to react to that, and then to be able to go through the whole research and development process of being able to create something that will tackle the issue, that process often takes years. So
it does.
It's only been in the last probably 8 years or so that we've seen these sort of products on the market, where pads and wipes and various different things to actually disrupt biofilms, where we've been talking about it in the way that we're talking about it this evening. So before that, it didn't really exist. So loads more questions. Question number 6, this is for you, Val. This is really interesting, quite a specific question as well. This is from Cora, and this is: once a patient becomes vancomycin resistent, how would that impact the management of wound infection?
So you mean vancomycin resistant Staph aureus?
Yeah, I assume so. It just says vancomycin resistant.
Yeah, I assume that's what you mean. I mean, there are other vancomycin resistant, multi-drug resistant organisms with enterococci, group D streptococci. And we've seen the vancomycin gene jump from the group D strep into another organism and then land in a Staph aureus, making it vancomycin resistant. Well, it's a massive problem, Cora, because we've had no new antibiotics, no new classes of antibiotics developed for nearly 25 years. So we've had existing families of antibiotics such as penicillin, erythromycin, ciprofloxacin. We've had them all modified, and we now have carbapenems and imipenems in the beta-lactam group, and we have very sophisticated cephalosporins. We do have linosolid, which is quite an interesting antibiotic, which will help with MRSA, but there isn't much left. If we actually look at antimicrobial susceptibilities of these organisms, once vancomycin goes, if we start to see resistance in linosolid, there's nothing else at the moment for that. Although, strangely enough, they're still often sensitive to things like tetracycline and chloramphenicol, which are very old school antibiotics. So the most important thing is when we do treat an organism, what we try to do now is we may give empirical treatment, but then we try to focus in, if we know which organism is causing the infection, we try to focus in with a narrow spectrum antibiotic. And it might be an antibiotic that you've perhaps not heard of or prescribed before, but there are some available, for specific bugs. So I think you'll see a change going forward. And hopefully, we do have vancomycin intermediate strains, and we've had them in Scotland. But we do try very hard not to allow them to become endemic in the population.
Well, Jen, anything you want to add to that?
No, I think Val covered more than I could ever answer in that question.
Brilliant. I know that the YouTube, before we went live, we're having a really interesting conversation about exactly that, actually. So it's very good that Cora sent that question in. Question number 7 from Debbie. Pharmacists have a key role in AMS, but not necessarily in wound care. Is this correct? And I'll pass that to you, Jenny.
That is an interesting statement, and she's probably right, Debbie. When I was doing my nurse prescribing, I spent a lot of time with the antimicrobial pharmacist, and if anybody gets an opportunity in their organisation to do so, I absolutely would recommend it. I know my pharmacy colleagues in London and Edinburgh are watching tonight, so hi guys. But absolutely, I think, and you know, I might live to regret this, but I would like to see pharmacists far more involved in antimicrobials when it comes to wound care, because they're absolutely key players in terms of strategic oversight. They do ward rounds in terms of antimicrobial stewardships. But you're right, Debbie is right. You know, pharmacists do take that step back when it comes to antimicrobials in wound care. And like I say, I might live to regret this, but I would ask pharmacists to challenge their nurses. After watching this, hopefully pharmacists on the wards or in the communities or on the high streets can now say to the prescribing clinician, is that acute or chronic wound that you're prescribing that for? Does that have a biofilm, do you think? If it does have a biofilm, are you sure you're actually debriding that biofilm before applying this antimicrobial? So I would like to see pharmacists step forward and challenge us nurses.
Yeah, good. And Debbie, just to add to that, you know, often you've obviously asked the question. I wonder whether there's a specific pharmacist you have in mind. Don't forget that this video will be available on our website and Facebook page. Maybe you can send them the link if you ever tell them to watch it themselves, if they don't talk to you about this in the way that you're after. Number 8 is from Laura, and that is, what national frameworks are there available to read further, please? Perhaps I'll answer this because only because we've got a couple more questions and I'm aware of time. With regards to national frameworks and things like this, we're going to put links to all of the content onto our website alongside all of the slides from this evening and an edited version of the video, which you'll be able to watch forever and ever. And what we'll also do is we'll also put links to those specific frameworks on there. So have a look out on our website, which is jcn.co.uk/Facebook Live from tomorrow afternoon, and everything that you're looking for will be available there. Question number 9 from Janet. Have you got any advice on implementing the AMS pathway into practice? Either one of you, maybe perhaps Val?
Certainly, mine would just be very pragmatic. Mine would be about making sure that you are educated sufficiently and you feel confident enough to ensure that within your trust or within your local healthcare environment, that you challenge the people in charge to say, what are our pathways? You know, this is what we need to do. We need to be thinking about antimicrobial resistance and we need to do something about it. What are our pathways? The actual art of implementing in the NHS is not me. That's definitely Jenny. She will have done this a number of times, I would think.
Jenny?
I think my only kind of addition to that, Alec, would be to challenge behaviour also. I think absolutely we have to be following these pathways because it's best practice, and then we can ensure patients are receiving the highest quality care. But I think we need to be challenging the just in case attitude and approach. So sometimes you hear clinicians say, I'm going to swab that just in case, or I'm going to get some antibiotics just in case.
Just in case.
I'm going to pop something on there just in case. We need to be challenging that approach.
Yeah, I totally agree with that. Anna is our final question, and this is question number 10, and she asks, what do you see the future holds if a change doesn't happen? And I think we'll pass this on to the two of you. We'll start with you, Val.
And you think coronavirus is bad?
That's it, is it? That's your answer? Yeah.
The reason I say it like that is we've had no treatment for coronavirus and we're desperately looking for it. We've had treatment for the last 80 years for many medical conditions and we're running out. It won't be there. So unless there's some radical new thoughts, research goes forward, we've got to keep the best for the worst type of infections, and we've got to stop using antibiotics and antimicrobials unnecessarily.
Yeah, I think there's also Jenny. What before I make my comment, what do you think about that?
Just to reiterate what Val says, Alec, it's quite frightening. In 30 years' time, there's going to be more deaths because we're resistant to antibiotics because we've misused them than cancer. That is quite frightening. Yeah.
There's the resistance, but then there's also the sort of the mutation of these things as well, isn't there? Because I always think about when you look at domestos or toilet duck or something that this is making it very basic, but it talks about the fact that it'll kill 99.9% of anything, and the reason that it leaves that 0.1% is because by the time they've printed the label, whatever it can prove that it killed could have mutated, so they can't actually prove at that point by the time it hits the supermarkets that it could kill it. So you've got to use antimicrobials very carefully in order to make sure that we can keep up with viruses, bacteria, everything else that we're trying to treat with it. So tonight has been a really interesting session. I think I've learned a lot, as I always do. Jenny, Val, honestly, it's been great working with you. I think that the two of you have done a tremendous job. Thank you very much to Essity for supporting this evening and preparing the presentation with Val and Jenny. For everybody who's joining, you should have the link to the certificate to download on your screens now. We'll put this presentation along with the slides and any links that we've mentioned throughout the presentation onto our website from tomorrow afternoon. We'll be back next week on Monday, Tuesday and Wednesday, believe it or not, with our JCN Live. We were due to do 13 face-to-face events this year, and we weren't able to do it for obvious reasons. So we're bringing them to you on Monday, Tuesday, Wednesday via Facebook next week. So please do join us if you can. Ladies, thank you very much for this evening. Audience, thank you very much for joining us. The questions have been wonderful. Just one more thing. If we haven't answered your question tonight, what we will do is we will answer it via, we download all of the questions and comments tomorrow. We'll then answer those, and then we create a Q&A and we put it as a PDF next to the presentation via our website. So do keep an eye out for that if you asked a question that we didn't get through to. I think that's it. I've realized that I put some tomatoes in the oven at about 6:30 and I've been smelling them burn for the last half an hour, so I'm going to go. Thank you very much, and good night, everybody.